So in this next module, we're going to go over vasopressors and how to use those. And so by the end of this talk, I think you should be able to explain the mechanism of action for vasopressors. And I think you should also be able to discuss the indications and contraindications for different types of vasopressors. So how do vasopressors work? Well, they have a couple of different mechanisms, but for the most part, what they do is they take this sort of dilated, floppy vascular system and they just increase the tone to kind of shrink it back down to normal. So usually what they do is increase systemic vascular resistance, and we typically refer to that as an alpha effect, because most vasopressors do that by binding to the alpha adrenergic receptors, which are expressed in the peripheral blood system. Now, that's not the only thing they do. They can also increase your heart rate and increase your contractility, so they can make the heart beat faster and make it beat stronger. And we typically refer to that as a beta effect, because that's mediated by the beta adrenergic receptors that are expressed in your heart. There are 4 different vasopressors that we're going to talk about here: norepinephrine, phenylephrine, epinephrine, and dopamine. So each vasopressor that I talk about, I'm going to put into this table here so that you can kind of contrast and compare. So you're going to see the name of the vasopressor, the degree of systemic vascular resistance it offers, the effect on heart rate, the effect on contractility, and then the dose. And you'll see them all together in the same table. The first one I'm going to talk about is norepinephrine, and it gets 3 pluses for systemic vascular resistance and 1 plus for contractility. Norepinephrine is easily the most common vasopressor that you're going to see over and over and over again. And we like it because it has really good alpha activity, and it also has like a little bit of beta, so it's actually got kind of a good mix. We use it the most, mostly because the data tells us that we should be using it the most. So when you look at critically ill patients in ICUs and that sort of thing, they tend to do just a little bit better in terms of mortality and outcomes like that. And notably, the big difference seems to be that they get fewer arrhythmias, especially in sepsis and cardiogenic shock, when you compare it to all of the other vasopressors that are out there. And that's probably because it has mostly that peripheral squeeze and not a whole lot of that contractility. The general trend with vasopressors is the more contractility you get, the more PVCs you're going to see, the more AFib you're going to see, and the more problems like that you're going to get. So in general, norepinephrine is usually the first-line vasopressor for most types of shock, with a couple of little exceptions there. But if you don't really know what's going on with the patient and you need to use a vasopressor, norepinephrine is almost always the first one that we end up reaching for. So the next vasopressor to talk about is phenylephrine, which is quite comparable to norepinephrine in a lot of different ways. And specifically, it seems to have about as much impact on the systemic vascular resistance that norepinephrine does, with a really strong peripheral squeeze. And some people say it might even be a little bit stronger in terms of that peripheral squeeze when compared to norepi. It doesn't have any impact on contractility, and as far as heart rate goes, sometimes it actually pushes the heart rate down a little bit. And the reason for that is because phenylephrine just has pure alpha agonist activity. It's just alpha in a bottle. All it does is give you peripheral squeeze. It doesn't really have an impact directly on your heart. And the bradycardia that you get is sometimes a reflex reaction to that. So if I punch up your blood pressure a bit, your baroreceptors will sometimes detect that, and then to sort of level out your cardiac output, sometimes they'll actually slow down your heart rate a little bit. That can actually happen with norepinephrine as well, but it's much less common. And the reason for that is because norepinephrine has this little extra boost to contractility. So it's got a little bit of compensatory beta activity that phenylephrine doesn't. So your heart rate doesn't really slow down because there's another mechanism that's kind of speeding it up. And in norepinephrine, those two things just sort of cancel out most of the time. Phenylephrine, though, sometimes you'll get a little bit of slowing of the heart rate. The other consequence to not really having any compensatory beta is that you don't really have any boost to contractility, and all you've got is this pure increase in systemic vascular resistance, which actually equates to a pure increase in afterload. So most of the time, this increase in afterload isn't really going to matter, but if you've got a patient that's got really bad CHF or they're in cardiogenic shock, you worry about sort of making that heart work harder, like increasing the pressure that already sick or weak heart is going to have to push against. And we worry that this might actually make people worse. So it's a little bit controversial, but generally speaking, we try to avoid using phenylephrine in cardiogenic shock and in bad CHF. So if you're looking at this and you're thinking, okay, well, phenylephrine and norepinephrine are super, super similar, but phenylephrine comes along with all these side effects, so why would I ever use it? Well, I think the reason you need to know about phenylephrine is because it's often used as what we would call a push dose vasopressor. So this refers to a vasopressor that we'll sometimes use as a bolus dose rather than a continuous infusion. And typically you would use a push dose pressor when you're in a scenario where you've caused the hypotension. So a good example of this would be like a procedural sedation. You're trying to reduce a fracture and you give them a whole bunch of propofol, but you gave just a little bit too much and their blood pressure dipped a bit. Or maybe the peri-intubation period where you've given them just like a huge whack of an anesthetic drug to put them to sleep, but maybe you give a little bit too much and their blood pressure dipped a little bit. You can use just little squirts of phenylephrine to help stabilize their blood pressure and kind of get them over the hump until their blood pressure just comes back up as those medicines wear off a little bit. Now, this is a medicine that you often have to mix up yourself. Now, luckily, this is very, very easy to do. All you got to do is find a vial of phenylephrine, and it typically comes in these 10 mg per mil vials. Usually, it's only got 1 mil in it. So take a syringe, suck the whole thing up, and then you're going to squirt it into a saline mini bag, so just 100 cc's bag. And what that gives you is 10 mgs in 100 mLs. If you think of that in terms of micrograms, you're looking at 10,000 mics per 100 mLs. If you cancel out all those zeros, you're dealing with 100 mics per mil. And if you remember from the previous page, the usual dose of phenylephrine is something like 100 to 200 mics per minute. So let's say you're doing an intubation, their blood pressure drops, you got phenylephrine ready, you just squirt in 1 mil, squirt in 2 mils, and that'll buy you a couple of minutes until the intubation medicines wear off and their blood pressure starts coming back up. So really, really useful tool, and this is a medicine that you should know how to mix up. So the next vasopressor to talk about is epinephrine, and you'll remember this one from treatment of anaphylaxis. And if you look at the table, you'll see that its properties are quite a bit different from norepinephrine and phenylephrine. In the first place, with respect to systemic vascular resistance, it's still got some peripheral squeeze, but it's just not quite as strong. And where it really shows a difference is in its impact on heart rate and contractility, where the effects are a lot more pronounced. And this is because epinephrine has both alpha and beta effects instead of the other two, which are mostly sort of alpha agents. Some of this effect is dose dependent. So we know at very low doses, you'll get mostly a beta effect out of epinephrine. And as you increase the dose, you'll hit a ceiling on that beta effect relatively quickly. If you keep going further into the higher doses of epi, you'll start getting most of that peripheral squeeze. So epi is a little bit finicky from that perspective. The beta effect, which is really what distinguishes epi, does make it very prone to arrhythmias. So we already talked about, the beta effect causing people to throw PVCs or flip into AFib or that sort of thing. And that kind of phenomena is quite a bit more common with epinephrine. So we tend to avoid it as a first-line agent, except in the case of anaphylaxis. So in anaphylaxis, this is really the pressor of choice because that beta effect is expressed not only in the heart, but also in the lungs. So you remember the beta-1 receptors are cardiac, but the beta-2 receptors are pulmonary. So in addition to fixing someone's blood pressure with a dose of epi, you can also get some bronchodilation, which is really helpful if you've got a patient that's got some wheezing or respiratory effects that you might see in anaphylaxis. And the other place where epi really shines is just in how quickly you can deploy it as an infusion when you really need to. So just about all of these vasopressors need to be mixed up by somebody before you can hang a bag of them. And you probably don't know how to do that. You probably rely on the nurses to do it. So if you need a vasopressor right now and you don't have time for somebody else to mix it up for you, you can do this yourself using something called the dirty epi drip. This is really, really easy. So all you got to do is head over to the crash cart and get a vial of epinephrine. Doesn't matter what it looks like or what the concentration is, because on the crash cart, they're all going to contain 1 milligram. So you draw up that 1 milligram, and then you're going to squirt it into a 1 liter bag of normal saline. That effectively gives you 1,000 micrograms in 1,000 milliliters, which if you cross out those zeros reduces down to 1 mic per mil, which is a reasonable concentration for any kind of infusion. You'll remember from the previous slide that the dose of epinephrine is something like 2 to 20 mics per minute. So all you got to do is play with the roller on the IV until you think you're getting about sort of 2 to 20 milliliters in there. Now, they call this the dirty epidrip because you won't really know exactly how much you're giving, but that concentration is sort of hard to screw up. Like, even if you hung this wide open for a couple of minutes, it's probably not going to be high enough to really hurt anybody. And so you can just sort of hang this, open it up, and then see what happens to their blood pressure. If it's too high, you can sort of roll it down, and if it's not enough, you can just open up the infusion a little bit more. You're not using one of those programmable pumps, so you don't exactly know what you're doing. But if this has come to a point where you're the one doing the mixture for the vasopressor, you probably don't really care exactly how much you're giving them. You just want their blood pressure to be fixed. So this dirty epidrip is kind of an easy way to get yourself out of a jam if you're stuck and doing this all by yourself. The last vasopressor that we'll talk about very briefly is dopamine. And if you look at that table right away, you'll see that dopamine shares a lot of characteristics with epinephrine in terms of its impact on systemic vascular resistance and heart rate and contractility. The dosing is a little bit different. So epinephrine is just a straight micrograms per minute kind of dose, but dopamine is a weight-based micrograms per kilogram per minute dose. So you got to watch out for that, but that's a fairly minor point. Just like epinephrine, dopamine has both alpha and beta effects, which helps explain sort of its profile. And it also has that same dose-dependent effect, where low doses give you mostly a beta effect and high doses give you mostly an alpha effect. But we think that this is probably more pronounced in dopamine. And some people go so far as to say that low-dose dopamine is almost like a completely different vasopressor when you compare it to high-dose dopamine. So it's more finicky that way. Just like dopamine is also very prone to producing arrhythmias. And some people think that that's actually even worse in dopamine than it is in epinephrine. So you've also got to watch out for that. And if you're looking at this information and you're thinking like, well, if dopamine works pretty much the same as epinephrine, except it's got all of these extra side effects and caveats and doses and stuff, why would I ever use dopamine? I think you're on the right track. There's a lot of people saying the same thing, that dopamine is just like an old drug looking for an indication. But dopamine does have one big advantage to it in that it comes in a premixed bag. So we talked about all these vasopressors needing to be mixed in some way before you can hang them, but dopamine is the big exception to that rule. You can basically just like find it in the crash cart, open the bag, and hang it, and you're done. So it's really the fastest one to use despite all of its side effects. And because it's so easy in that sense, you still see it in really resource poor areas. So like in the back of an ambulance, you don't want to be mixing a vasopressor and like trying to drive a bus at the same time. So sometimes dopamine is used by the paramedics there. And you'll sometimes see this in very, very rural areas where it's just like you running the code and you've got like one nurse to help you out. And that nurse doesn't have any critical care skills. So you're the one that's got to manage the vasopressors. Dopamine is really helpful in that case because, again, you can just open the bag, hang it, and then you're kind of done from there. So dopamine really is like a last line vasopressor that you're not going to see used a whole lot, but I still think it's one that you got to know about because it's still got some advantages that work in very specific circumstances. Okay, so to wrap up and summarize, let's talk about vasopressors in the context of different types of shock. So we first started with hypovolemic shock, where we said that the problem was that the tank was empty. And in this circumstance, we said we'd treat it by giving them fluids or giving them bloods just to fill them up again. In this case, there's probably not a huge role for vasopressors because if they're empty, you just need to fill them up again. You don't really need to screw around with systemic vascular resistance or heart rate or contractility or that sort of stuff. If they're empty, you just fill them. In distributive shock, we said that the problem was that the pipes were floppy, that the system had lost its tone. And we said that we would treat this with fluids to fill the extra space or vasopressors to increase the tone back to normal. And the ideal vasopressor depends a little bit on the underlying etiology. Most of the time we're reaching for norepinephrine because the data tells us that that's probably the most effective one, particularly for sepsis, because it gives you the best impact on the systemic vascular resistance out of the options that are available with the fewest side effects. The exception there is going to be anaphylaxis, where you want that extra beta effect, mostly for its bronchodilation to protect the respiratory system. In cardiogenic shock, we talked about a broken pump being the etiology, and we said that we would use fluids very gently, making sure that we didn't cause fluid overload or pulmonary edema, and that we would use vasopressors if that little bit of fluid wasn't doing it. Now, what vasopressor you use is also a little bit tricky. So you might think that you'd reach for epinephrine or dopamine just to increase the contractility, but that's really only a good idea if the patient is bradycardic and you really want to bump up their heart rate. Just about all other circumstances, norepinephrine seems to be the safest one to use, probably because it has just a little bit of contractility, and that seems to give us the most benefit with the least risk. A sick heart is an irritable heart, and if you pump it full of beta stimulation, you might produce an arrhythmia, which is just going to create more problems than it's worth. And the last kind of shock we talked about was obstructive shock, where there was a blockage in the pipe somewhere. And we said we would treat that by trying to alleviate the obstruction. And until you can get that done, you're going to temporize the situation with some fluids and some vasopressors there. What vasopressor you use is sort of tough to say because there's not really a whole lot of good data on this. Most of us in these circumstances, I think, are probably reaching for norepinephrine, mostly because it's convenient and we're comfortable with it and it's first line for everything else. But that's not really driven by any convincing data, so you'll probably see some variation in practice here, and I think just about any vasopressor you reach for would be reasonable. So that's it. That's the end of this talk. We have one more talk coming up to finish the module where we're going to talk about integrating fluids and vasopressors and just trying to be more nuanced about the approach.